Dear colleagues, welcome back to Endo Channel by Gianluca Plotino and my course on non-surgical endodontic retreatment. And this specific lesson will deal with one of the chapters, the last chapter of this course, that the first half of this chapter will describe the treatment of perforation, the repair of perforations. And this is the specific topic that we will deal in this video lesson today: how to deal with the presence of the perforation and all the clinical techniques that you can use to repair the perforations to obtain the best outcome possible for your clinical practice. Always when we have an alteration of the endodontic anatomy, we have some panic situation because we know by the existing literature that when we have a pre-existing alteration of the canal morphology, of the endodontic morphology, when we start to perform a retreatment, we may have a very high drop in success rate. Stated by this article, 40% drop in the success rate when we have an alteration of the original morphology, rather than in the cases in which we don't have these altered anatomies. So we know that the pre-existing alteration may influence so much the prognosis, and perforations is one of this type of pre-existing alteration that has been investigated, influencing and reducing the anatomy, the outcome of our treatment. Then we will have other clinical situations like the apical resorption, internal or external transportation, stripping, or internal resorption that may reduce the prognosis of our endodontic retreatment. But today, we will mainly deal with the presence of perforations. And let's start by defining the perforation. Perforation is an endodontic-periodontic communication of iatrogenic origin, either those located at the pulp chamber floor or in the lower third of the canal space. We know that this is a iatrogenic error, even if there can be also perforations not iatrogenic, for example, given by internal or external root resorption or cervical resorption. But mainly they are done by our hands and they are a iatrogenic error. We know from the articles that the success rate for teeth with perforation without a preoperative perforation was 32% higher than the success rate for teeth with preoperative perforation. So the perforation may influence negatively the prognosis. In this systematic review and meta-analysis, one of the conclusions was that the clinical cases with absence of a preoperative radiolucent area adjacent to the perforation site showed a significantly higher success rate than those with the presence of radiolucency. So again, we clearly know that the success rate is influenced by the presence of bacterial contamination. And of course, if we will have a radiolucent area nearby the perforation, there is for sure caused by the presence of a bacterial infection. And so this will reduce our prognosis. If we have a perforation without any sign of periradicular problems or periradicular lesion, probably we have a non-infected perforation that can have a better success and a higher success rate. From this study, we know that there is little difference in the healing regardless of the location of the perforation. So from this review and meta-analysis, we have these conclusions, even if we know that the location of the perforation may influence somehow the success, especially if the perforation is located in the cervical area, in the sulcular area, in the sulcus, in extra bony position. Because parallel and concomitant parodontal infection may come in the perforation area and may create the possibility to have a lower success rate. If we have an intrabony lesion or an intrabony perforation in a portion of the root that is in the bone, This is more difficult to be accessed by the clinical procedures, but in the same time, we don't have contact with the external portion of the tissue. So the prognosis is higher if the perforation is at this level. Again, in this systematic review and meta-analysis, they have concluded that maxillary teeth exhibited a significantly higher chance to heal when compared with their mandibular counterpart. And they try to find an explanation of these conclusions by the rich vascular network supplying the maxilla that may help to promote healing.